how does PSSD work on a cellular biochemical way. It's complicated, clearly. We've done ultrasounds on these folks of their genitalia, of their penis. And remember, I'm a radiologist, so I like physics and I like objective information. Their tissue is not normal at all. So a normal, healthy young man, their penile tissue should be homogeneous. Their smooth muscle, everything should be homogeneous, symmetric. These people have fibrosis. There's areas of fibrosis. Of scarring is another term. It's not just scarring, it's scarring the entire shaft, essentially, of the penis. The people that I'm looking at are 70% of them are less than 30. They don't have diabetes, they don't have hypertension, they're a 25-year-old guy. And so their penis looks like an 80-year-old diabetic who's smoking and is obese and has hypertension, hyperlipidemia.
Okay, so I'm really excited to be joined by Ahad today, and he's a PSSD researcher, and it's actually the first researcher aside from David Healy who I've been lucky enough to speak to. He has a long list of scientific credentials, and he's working with Dr. Goldstein's group out at San Diego Sexual Medicine, where they're reviewing charts of people with PSSD, and they're contributing to the research literature in putting together diagnostic criteria for this condition. So we're going to talk all things PSSD today, and I'm specifically going to be talking about the diagnosis of PSSD and how to recognize it, and all that useful clinical information. So Ahad, welcome. Thank you so much for being here. Maybe just start by telling the audience a little bit about your background and how you came to be interested in this problem.
Sure. So thank you very much for inviting me. My name is Dr. Ahad Waraich. Give you my educational background. I was a biology major at the University of Chicago. I have a medical degree from the Johns Hopkins School of Medicine, and I have a master's in public policy degree from the Harvard Kennedy School of Government. Through my, at Hopkins and Harvard, you get connected to a lot of different folks. And through the grapevine, I heard about Dr. Goldstein, who was actually originally in Boston before he went to San Diego. And he's well known in urology, in the urology community everywhere, including Hopkins and Harvard. He's held in very high esteem. And I was looking for research, to do some research after my med school before I started my residency. And he was doing research on basically iatrogenic effects. He's done research in post-finasteride syndrome, which is not necessarily the topic of discussion, but that's also a syndrome that he has kind of led the research in. And so he was also looking into another post-drug syndrome, so to speak, called PSSD, post-estradiol sexual dysfunction. And there was a radiological component to it, which I'll get to. And I'm actually right now a radiology resident. And so there was a radiological component to this, which fascinated me, which no one has done research on in terms of this condition. And he's a charismatic person, and I felt this would be a good project. And I've been working on it for a number of years now.
Yeah. And I think it's, something that I'm always interested in. And, I know Dr. Goldstein is very respected, but I would say he's at odds with health regulators, governing institutions and things like that. So what's that been like? Well, to be on a team with someone very well respected in academia who is kind of sounding the alarm on PFS, PSSD, and such, and for that to be at odds with what I guess the rest of the established medical profession is saying.
Well, Dr. Goldstein's whole career has been one of revolutionizing thought. Yeah. He himself, has had theory. He always jokes about the fact that he never thought there'd be a pill for erectile dysfunction, and then he ended up being one of the main people on the New England Journal of Medicine on the Viagra research. Wow. So this is how science works. Mm-hmm. There's certain thoughts about how things work. His argument was, a pill would be systemic. How can we don't want to lower, blood pressure everywhere, and how will that work? Well, we didn't know that there was, something that was specific to, tissue-specific entities, right? I mean, that was very surprising. And now it's just common sense. Mm-hmm. Every pre-med, every biomajor knows this. And so, yeah, he has an extensive career. I can't even begin to talk about all of the things he's done. But yes, He's someone who very passionately believes that the point of medicine is to help patients. And if what patients are saying or what they're showing, both objectively and subjectively, is at odds with the current established medical understanding of things, then we need to investigate further. He's been at the forefront of women's sexual dysfunction in terms of flibanserin and those drugs. Many people thought, that was nothing, that wasn't even a real condition. And yet now we have two drugs, actually, Vyleesi and flibanserin, for a condition that many people felt was not even real. And those two drugs are doing well. And Dr. Goldstein believes that science is about analyzing and revamping our understanding constantly. So it's been a great experience with him because, I've seen both sides of the coin. I mean, I was at Hopkins. You talk about the medical establishment. I mean, Johns Hopkins is obviously the leader in medicine, but even at Johns Hopkins, yes, there were doctors who were old school and go by the book, but there were doctors there too who were, it's the number one research institution in the world because they believe that we need to constantly update our guidelines. And so there are folks at all institutions, some of, in the old guard and some who want to constantly research and do things. Some are more public than others in their fight, I would say. But I've seen both sides of the coin. I think there's value. We shouldn't be skeptical of every single thing immediately. We have to, be reasonable in our skepticism, if that makes sense. So I've seen it both at Hopkins and at Harvard. And Dr. Goldstein certainly represents the type who says, let's be skeptical of things and let's try to challenge things if we have enough data and enough evidence.
Okay. And he has challenged it, and I know that the group is supportive of PSSD, and I think now's probably a good time to get your perspective on this. So from the research that you've done with his group, how do you define PSSD? What because at least from what I've seen, there's lots of people not on SSRIs who are claiming to have PSSD, and it seems to be this kind of big umbrella for sexual dysfunction with psychiatric medications. And I was just wondering if you could kind of share your thoughts on what is PSSD technically? Has it just become this big label for all of these things? I'd love to hear your thoughts on that.
Yeah. So with the caveat that obviously definitions are further refined, constantly based on research. But I would say that my basic understanding and the basic core definition in the literature is PSSD is an iatrogenic condition from SSRIs and SNRIs in which a patient develops sexual dysfunction. We can talk about sort of the nuances in a second, but there's some key things in that statement. One, it's iatrogenic. It's from the drug. So now it's not sexual dysfunction from, a depressive disorder, from a psychiatric disorder, from it's not a psychogenic induced sexual dysfunction. And that's very key, as we'll talk about. SSRIs, SNRIs are obviously the main class that we're talking about. And the other component to this, and the other part of the definition that's absolutely essential, is that it persists, or it stays, or it happens even when the patient is not taking the drug anymore. And that's the key component. I was going to say persist because the majority, or the vast majority actually, of patients, they take SSRI, SNRI. It's very well known and accepted in the medical community that, sexual dysfunction is a common side effect of SSRIs, SNRIs while on the drug. That's not really disputed. I mean, that's part of our step one exam in our board. That no one debates that. People may debate the prevalence, is it 40% or 30% or 50% or whatever, but the fact that it's a side effect, no one really disputes that. It's one of the most common, if not the most common side effect. But the interesting thing about this is that PSSD is post-SSRI. That's what the P stands for, meaning that you're off the drug, so you take, Lexapro or whatever, SSRI, you develop sexual dysfunction while on the drug. You stop the drug, and yet your sexual dysfunction is still there. It doesn't go away. The traditional, conventional understanding is that you take the drug, you may have a side effect like sexual dysfunction, but once you stop the drug, the side effect should go away. That is the conventional wisdom. That is still, I would say, what most people think, most clinicians think. That's how we're taught in med school. But this is saying that no, there are some people for whom this sexual dysfunction persists. And for those, we say it's post-SSRI or SNRI sexual dysfunction. I will give just one little caveat. There are a few patients, although it's a minority, certainly, where they say they didn't have sexual dysfunction during the drug, but then they developed after, they discontinued it. I would say there would be more research needed into that particular field, into that particular cohort, I would say, because even the charts that I've reviewed, I can't give you an exact number, but I would have to look back. But the vast majority is where it persists. They developed a sexual dysfunction while on the drug, and then it persisted after discontinuation. And that is the traditional, conventional sort of definition of PSSD since it was first brought to the literature in 2006.
I think it would be interesting to hear more of those stories. When I've heard that, it makes me think of tardive dyskinesia, which is the other persistent problem. And another interesting thing about TD is TD can appear for the first time during drug withdrawal, and that seems really unusual as well. But I think that is recognized. So at least there's an analogy within another drug class of a persistent neurological problem only occurring upon withdrawal. But I guess right now we need more cases before we can say that's seems to be consistent with the PSSD folks. Yeah.
Right. That would be a good analogy for those who argue that you can develop PSSD even during withdrawal, basically, that you don't have to have the dysfunction during the drug. I would say though that the majority of patients are the more I developed a dysfunction on the drug and it persists even after discontinuation, months, years, after 10 years.
So I'm going to be picky a little bit here. I know you mentioned specifically SSRIs and SNRIs. What about some of the tricyclics as well? Because there's a lot of very serotonergic tricyclics out there, things like clomipramine. Were they purposefully left out, I guess, of the definition, or is it just, what about those folks out there? Because I know I've spoken to some of them who say they're experiencing something similar following tricyclic use.
Yeah, I would say that I think for the papers that I've read, they have generally limited to SRIs, SNRIs, and including our research from just the get-go, because we were just basing it on that definition, we chose patients who are on SSRIs and SNRIs. But that does beg the question from a biochemical perspective: why would another serotonergic drug like a TCA or something else not cause a similar sort of effect? And it's certainly possible. I just personally, we sort of made that definition, or not made the definition. We kind of followed the original definition from the get-go in our research. So it would be a good question, and this could be further research to ask Dr. Goldstein about, if he has patients who are on TCAs.
Yeah. As I spoke to someone on the podcast several months ago, Carlton, who had taken, I think it was clomipramine or something like that, or imipramine, and he had a reaction like that. I've heard anecdotally stories of people who have said that they've experienced similar things on the other antidepressants, things like Wellbutrin, and also things like mirtazapine, which start to kind of veer a little bit because we don't typically think of those drugs as being very serotonergic. I know there's always cascades of different effects that happen with the drugs, but I do see PSSD being used as the term for persistent sexual dysfunction on those drugs which are not classically thought of to be highly serotonergic. What are your thoughts on that?
I would say, at this point, it's sort of this research and the research that's been done has been based on patient, what patients are saying, right? So, a bunch of patients with SSRIs, reported this, and then Dr. David Healy and a few others, started reporting this, and then it was, okay, it's not just SSRIs, also SNRIs, let's add that one on. I mean, the original definition was just post-SSRI. It didn't even have SNRIs. And then it was like, well, certainly SNRIs, and that also makes sense. I mean, but SNRIs should be added. And obviously that's, SSRIs, SNRIs are the majority of antidepressants this day and age. But remember, we're not like studying
Sure.
mice here, right? We don't really know the exact biochemical pathway in which all of this is happening. And so in terms of, there are different theories, obviously, are the receptors desensitized, permanently? Are there epigenetic changes? Is there some sort of combination of serotonin, dopamine sort of dysregulation? All these theories. There's a great paper comparing by Dr. Mulcahy comparing PFS and PSSD. And obviously, finasteride is, a very different, or ostensibly, I should say, a different,
Yeah.
completely drug class, everything. But and again, he was proposing mechanisms, but he was like, is there some commonality between PFS and PSSD? And we don't know. I mean, to be honest, we need more research. And so I would say, are these, how much commonality does PFS, PSSD have on a biochemical level?
Hmm.
I'm not sure. Um, I think in terms of, I think the general idea, which is what you're getting at, is absolutely crucial, is that the idea of post-drug, quote unquote, syndromes, um, and tardive dyskinesia is the one thing that, again, we get taught that in med school.
Hmm.
That's not really disputed anymore. We know of that, but most doctors and most patients, for most drugs, it's like you have a side effect and goes away when you stop the drug. That's sort of the general concept. I think the paradigm shift here is similar to tardive dyskinesia. Are there other drugs, that can cause these side effects that even when you're not on the drug? And so, do we need to create a different term like PSSD versus post TCA syndrome or post,
Oh
Accutane
yeah.
actually
Hmm.
another drug, in the derm community that's been researched. In fact, there's a website, that's basically PFS, PSSD, and post Accutane syndrome. So these are three completely, ostensibly very different drugs, and for different indications, all that. So this is more of a classification sort of thing where, yeah, the people who are saying they take TCAs or other drugs and they have similar components, maybe that's another thing. And then it's just a matter of how much commonality is there and do we need to have different terms?
Yeah, I think the point to make is that it really is an evolving science, and I guess when the research project started, it sounded like you were looking for a very pure sample, so you could do very good, consistent research on something. You weren't trying to take a stand and say it only happens with this class of drugs. That was just where you were starting, and then as
Right.
science evolves, new terms may be available. Yeah, the terms may be updated, and it's just kind of where we are at the moment.
100%. So it wasn't as though I went through every single chart he's ever done and was like, okay, which one of
Mhm.
these have a post-drug syndrome? And oh, X percentage or SRI, SNRI. That would be the study to get
Mhm.
at your question, basically. And not just Dr. Goldstein's, but everybody's patients. Everybody's taken a TCA or taken whatever, and then let's see how many of them have this, and then overall. But our research, or my research specifically, started off by saying the patient needed to have an SRI, SNRI in their patient history.
How many charts have you reviewed of patients who have come forward believing they've had PSSD?
So quite a lot. We keep for this research. Our goals, and I've been working on this paper for now almost 4 years now, and we keep sort of expanding this project because there's so many aspects to this, and we debated about splitting this up into little papers or bigger papers, and then we kind of keep changing our sort of inclusion exclusion criteria. Um, right now for the paper that we're probably going to try to publish at the end of this year, early next year, I think in the 40s, because we wanted a very very pure sample, where it's pretty much unquestionable in terms of their history, and that they have PSSD, their sexual dysfunction is due to PSSD. There is no other confounding factor whatsoever that anybody could point to and be like, oh well, it's actually because of A, B, and C. Um, Remember, in real life, just like with any medical condition, some people have
Sure.
multiple things going on, right? Someone could have, someone could have sexual dysfunction because of trauma, because of PSSD, because of whatever. There's multiple things, and so that doesn't diminish PSSD as a condition. But in right now, remember, our one of our goals, we have multiple goals, but one of our goals is to just again reinforce the fact that these patients, these are medical charts. These are not just a questionnaire that you enter online. These people show up in a clinic, headed by a doctor who's, well experienced, who has very detailed charts, who has very detailed history, physical exam, labs, you name it, radiology, everything, the whole 9 yards, and multiple visits in the vast majority of cases. So this is the most intensive of all the literature that's been done since 2006 when this first showed up. I would say this is in terms of the level of detail we know about these people, about these patients and their histories. This is by far and away the most. And so I really, for our purposes, wanted to make it a pure sample of like, this person has PSSD. There's no other reason for their sexual dysfunction, and they meet every possible criteria you can think of to meet this.
Well, firstly, God bless you guys, and I'm so happy you're doing this work. And I'm going to say you have no idea how much it means to some people, but you may, because if you've been doing this, you know that there's a lot of desperation when something like this happens. But it's just amazing work what your group is working on. I think you touched on something that I'd like to explore further, which is really the diagnostic criteria. So how in terms of the clinical features of someone with PSSD, what are they? And then how do you separate them from sexual dysfunction due to things such as vascular disease, performance anxiety, or I'm going to say psychosomatic causes? I don't know if you've talked about that before, but I know that's a common way that naysayers like to dismiss it by saying, oh, these are people who have a hard time, with sexual performance, and then they have just decided that they're going to latch on to the idea of having PSSD as a defense, and it's psychosomatic. And I mean, I don't like that argument, but I wonder if it's something that you think about when you're going through the charts and you're saying, how am I going to tease out that this is materially different from these other alternative explanations for sexual dysfunction?
So great question, and you're getting at basically my life for the past 4 years is teasing that apart. The great news is that, as I mentioned, these charts are very detailed, and Dr. Goldstein is a very detailed and thorough doctor. So I'm able to do this, that I don't think that, thus far necessarily anyone has been able to do to this degree. So absolutely 100%, could this be a psychogenic thing? I mean, that's sort of the main critic's argument. We'll get to trauma and those other things as well, but just in terms of the first thing that people will say is, well, these people have major depressive disorder or generalized anxiety disorder or some other psychiatric disorder. Obviously, they were given an SRI, SNRI for a reason. And we know that, just to take major depressive disorder, which is obviously the most common indication, that's known to cause, can cause sexual dysfunction in a number of people. Not everyone with major depression gets sexual dysfunction, but a fair number do. And so, how can we tell the sexual dysfunction was not from, say, a major depressive episode versus this drug? So there are a couple of things. So number one is history, and that's, half of med school is learning how to take a history properly. So to give you an example, in the chart, what I would be looking for is, I started developing depressive symptoms, and A, B, C, and D, you can go through the DSM criteria, blah, 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 I have this, and this. And then I went to a psychiatrist or my family medicine doctor, and I was diagnosed with major depression. But I did not have sexual dysfunction during this time. I couldn't focus, I couldn't concentrate, I was tired, all those sort of, you can go through the 9, the 5 out of the 9, the things that we learn in med school. So I met the definition for major depressive disorder, but I did not have sexual dysfunction at all. I was a healthy 25-year-old young man, who had great erections, great libido, or had orgasm, I had general sensation, all those sorts of things. And I'm literally repeating what I read in the charts. This is how detailed this is. Then I took a drug. I was prescribed Lexapro or whatever your favorite SSRI is. And I noticed that I took the Lexapro and my erections became weaker in terms of rigidity, in terms of how quickly the erection started, the duration that the erection lasted, and just, again, firmness. My libido tanked. I felt no sexual attraction. And then, even if I could manage a very weak erection, I would ejaculate without feeling any pleasure. So, pleasureless ejaculation, or, anorgasmia. There are a number of terms. Or pleasureless orgasm, and I didn't feel pleasurable sensation. It was like having 100 condoms on. I'm repeating exact phrases from the charts here. I felt like I had 50 condoms on my penis because I couldn't feel. And then I was on the Lexapro for whatever 8 months, 2 years, and then I was told that it'll be fine. It'll be fine once you get off the drug. And my depressive symptoms went away, or maybe and then I got off the drug after 2 years. Hooray! I'm off of Lexapro. And then I kept waiting and waiting, and I kept waiting. I was told it'd come back in a few days. Probably immediately, maybe a few days max. And I kept waiting. It's now 6 months, 8 months, and now it's a year. And my sexual dysfunction, the ED, the anorgasmia, the lack of sensation, lack of libido, it's still there. And I'm a 27-year-old now. When I'm at the peak of my you should be at the peak of your sexual function at this point, which I was before I took the Lexapro. It's no longer there. So so that's the classic story for PSSD, I would say. And so it's all about taking a history. And so that would be my number one point to your question. There are further things. Number two, major depression does not cause sensation issues. Like, that's not a thing. Major depression, if it causes sexual dysfunction, it can cause libido problems. It can cause, erectile dysfunction. It does not cause lack of sensation or general anesthesia. There are a number of terms for this. That's not a thing that depression is known for. If anything, we give for premature ejaculation, it's kind of the opposite problem, where you have too much sensation and therefore you ejaculate too quickly. And so we give a type of SSRI, if you will, for that, for premature ejaculation. So it's not completely crazy to think, oh, well, it might affect sensation in some way, except it's the opposite problem, where the drug takes away the sensation. As far as I've done my research, I don't know of any literature which shows major depression causing general anesthesia.
Well, let me say this, there's, because I'm going to play devil's advocate, because I know that somewhere someone's going to be saying this. They'll say, yeah, but, functional neurological disorder, conversion disorder, hysteria, whatever name you want to give it for these psychological symptoms. I've seen it cause paralysis in some people. I've seen it cause blindness in some people. Why couldn't it cause genital anesthesia? What do you say to arguments like that? Because I've heard them.
Well, I was going to give my third point, so I don't know if you're going to have an answer for the third one. So the third point would be, what we're doing is we've done ultrasounds on these folks of their genitalia, of their penis. And remember, I'm a radiologist, so I like physics and I like objective information. So objectively, it's really hard to argue against ultrasound, because we use it for everything, and it's sound waves. So basically, we have done ultrasound on these folks, and what we've discovered, and this will be one of the main aspects of our paper, is that their tissue is not normal at all. So a normal, healthy young man, their penile tissue should be homogeneous. Their smooth muscle, everything should be homogeneous, symmetric. These people have fibrosis. They have inhomogeneity. It's heterogeneous. There's areas of fibrosis. Scarring is another term to think about for the non-med people out there, that it's just, they're scarring. And if they're scarring, that obviously will not be conducive to an erection. And here's the other point. It's not just scarring, it's scarring in the entire shaft, essentially, of the penis. So what does this mean? So in people who have vascular problems like diabetes, hypertension, hyperlipidemia, heart disease, older 80-year-old man with diabetes, they have if they have erectile dysfunction from those vascular risk factors, they will have penile tissue that's scarred and throughout the penile shaft. But they're 80 years old with these 5 other risk factors that I just mentioned. The people that I'm looking at are, 70% of them are less than 30, and they have virtually no vascular risk factors. They don't have diabetes, they don't have hypertension. They're a 25-year-old guy with nothing, not overweight, not smoking, nothing. And so their penis looks like an 80-year-old diabetic who's smoking and who's obese and has hypertension, hyperlipidemia. So that's, and then the other cohort, and you had mentioned trauma earlier. So trauma, that can obviously happen at any age. You drive your bike and you get into an accident.
Before we go on to trauma, because this is such an interesting thing, when you see kind of fibrosis in the penile tissue, what does that say about the cause of PSSD to you?
Yeah, so, I don't want to jump the gun here, but yes. So what this suggests, and again, this goes back to my original point about, how does PSSD work on a cellular biochemical way? It's complicated, clearly, because obviously it's a serotonergic drug. There's serotonin in our brain, and, there's obviously the theories are surrounding the neurons in our brain. But what this suggests is that there's peripheral effects, right? And this is affecting the penile tissue. We're not talking about the hippocampus here. We're not talking about the brain here. We're talking about penile tissue. Again, why does that happen? And again, they're possible, not just for PSSD, but in general. Why does penile tissue scar? Why does it do that? And again, that's also sort of a hot topic of research. And there's no definitive answer. Some people have said something called reactive oxygen species, which is kind of a thing that you learn about in organic chemistry that can cause bad things. I don't know, to be honest. But what I can't really fight against is that I see a penile shaft that looks like,
Okay. And from the people who had clinical, like who reported the clinical symptoms consistent with PSSD, like the genital anesthesia and the loss of libido and such. I don't know if you may not have the exact statistics here, but maybe you could ballpark them. Do you know roughly what percentage of those people with those who reported the symptoms had corresponding changes on ultrasound? I guess just trying to get at how I guess sensitive and specific the ultrasound might be one day as a diagnostic tool.
Right. So I would say the vast majority so we would do ultrasounds on people who had erectile dysfunction. That was the ticket to getting an ultrasound. The vast majority of our PSSD cohort had erectile dysfunction. There were a handful. I don't quote me on the numbers because they're liable to change as I'm still working on this, but I would say less than 10%, probably less than 10%. And they would have the other problems, the libido and the orgasm issues and the sensation issues. But 90+% would have erectile dysfunction, plus those other symptoms that we talked about. And so of those people with the 90% of who had ED and thus got an ultrasound, the vast majority had some level of erectile inhomogeneity. I mean, the vast majority. I'd love to give you a number, but honestly, we're still calculating the numbers, so I can't tell you the number.
Hanging out for the paper. I hope it's going to drop a bombshell in the world, because it really should. Something this big.
Well, the other bombshell this is sort of related to the same topic, but the trauma cohort is very interesting because obviously young people also get trauma, and remember when people think of ED, they think of, again, the 80-year-old diabetic who's obese and who's smoking cigarettes and has, hypertension. These are 25-year-old healthy young men who have zero vascular risk factors, none, and their penis looks like the 80-year-olds. But then, we have another group of people who are in their 20s or 30s who, underwent trauma, because they were in a biking accident or whatever, or they're playing sports or something, and they have erectile dysfunction. So they're, roughly the same age group. Young people, in other words, trauma people. So they have fibrosis too, but their fibrosis is limited to a very specific part of the penis, the part that underwent trauma, right? So that makes sense, right? It makes sense that where they had the trauma, that's where the tissue is inhomogeneous. And so we have this PSSD group and these two control groups. We have a trauma cohort of young people, like the PSSD people. They're young, and they also don't have vascular risk factors or anything, and they have an homogeneity in a very specific part of the penis where they had trauma. And then you have the vascular group, which are 80-year-olds with a bunch of risk factors, and their penises look like the PSSD penises. So we have, no one's done this research before, and it, as you said, it's an objective, and that's what radiology is. That's why we use it in medicine. It's an objective way to assess things. And to your earlier question, the original question about is this psychosomatic or whatnot, I don't know about any psychosomatic thing that would cause tissue degeneration.
Mic drop. There you go. Yeah. I think, this is really, really exciting. I want to touch on another element that frequently gets rolled into PSSD, and I want to hear what you think about it. When I've probably spoken to, I'd say maybe 10 people with PSSD in the last year, not only do they describe the kind of the sexual dysfunction that we've been talking about, they frequently talk about a kind of an emotional blunting that's almost dissociative in effect. It's like I feel separated from the world around me. I'm having some difficulty thinking clearly. I have some brain fog, and very, very unnerving, very unpleasant, feeling completely disconnected from things. And many people have said that that's actually the thing that makes them the most unhappy about the condition. I was wondering if you could speak to that. I don't know if you've.
Right.
Do you think that has relevance in the diagnosis of PSSD as being maybe part of a syndrome, or just share any thoughts about that?
No, it's a very important question, both from an academic perspective in terms of defining this, and also clinically in terms of with patients. So here are my thoughts. I would say PSSD originally and classically, and in the majority of the literature thus far, has focused on the sexual aspects. From 2006 to Dr. David Healy's papers, they have focused on the sexual dysfunction. So the question is, are there non-sexual aspects to this? So here are my thoughts on this. I think, so if we go back to that patient example, they had something for which they were given an SNRI for, right? MDD, major depression, generalized anxiety disorder, some other psychiatric disorder. You could argue they may have been even misdiagnosed with depression. Maybe they were going through grief or heartbreak or something. But my point is that they were going through some mental distress for which they went to a doctor, and rightly or wrongly or whatever, they were given a drug. Okay, so we did a really good job, as I mentioned, trying to distinguish, those things, whatever their mental distress was, whatever psychiatric disorder they had or didn't have, from their sexual dysfunction, because we wanted to make sure that to argue against these sexual symptoms are not psychogenic in etiology, that they're iatrogenic, right? So we did that job. So now, okay, so let's accept that for a second. Now the question is, okay, this patient, they have sexual dysfunction. So there's a couple of things that can happen. So sexual dysfunction from any etiology is known to cause distress, and it's also been shown to lead to major depression. Any stressor, if sufficiently severe enough, and given obviously right genetics, blah blah blah, can precipitate a major depressive episode. Any stressor can, and sexual dysfunction is a stressor for many people. And so, and I can tell you that we have various means of measuring this, but pretty much everybody in the cohort of PSSD folks had very high levels of distress due to their dysfunction, sexual dysfunction. They were upset and angry and all those things. And I would not be, and a further cohort of that, whether they had originally major depression or they didn't have it, they may have developed depression secondary to the distress of having sexual dysfunction, right? So that's a possible group too. So that's obviously sort of reactive or secondary, if you will, to having sexual dysfunction. If they have, developed a major depressive episode due to that. The people you're talking about are claiming something different, though. What they're saying is that they're sort of, and remember, major depressive disorder, many of the symptoms include not being able to focus, not thinking clearly, being detached. I mean, the things you mentioned, frankly, are things that we learn about in major depression.
Severe states of anxiety can often precipitate dissociation and disconnection from the world as well.
Right, 100%. So yeah, anxiety as well. So, but what they're trying to say is, well, this my brain fog or my lack of cognitive focusing is from the drug itself. That's also iatrogenic. So then the job would be of a researcher and a clinician, but researcher at this stage certainly, is to be like, okay, your brain fog or your cognitive disassociation or your isolation, all those things you're mentioning, is this from the drug or is this, secondary to your distress from your sexual dysfunction? Now, as a thought experiment, let's say we came up with a cure to the sexual dysfunction, right? And we gave them something that allowed their sexual dysfunction to go away. If their major depressive episode was secondary to the distress from having sexual dysfunction, well, then that presumably the stressor is gone, so that should go away. If, however, their brain fog, et cetera, is from the drug itself, and their sexual dysfunction is cured, and they still have brain fog and they still feel detached, well, then that would suggest that it's actually from the drug. That's not a secondary, reactive depressive episode they're experiencing. That it's actually from the drug itself. If that makes sense. So in terms of, is it possible? Absolutely. I would just say that in terms of our research, in our charts, yes, we would have people. So, to continue that example, so I'm 27 years old, I have sexual dysfunction. Now I'm distressed and, I can't focus. Okay, so I'm like reading a chart for you basically. I'm distressed and I can't focus and I'm 27 years old. So when that sentence, do I interpret that I can't focus as, oh, this is a secondary depressive episode or, a reactive secondary episode to your sexual dysfunction, or is this actually also from the drug? I can't tell that. And our charts, remember, Dr. Goldstein's a sexual medicine doctor, right? So he, in terms of teasing that apart, that was not really the prime focus necessarily of his clinical visits per se, nor in terms of, and I think it's a very good thing to look into, but we need a way to develop and distinguish those two things.
Hey, just want to interrupt quickly and just say if you're enjoying the content that we're producing here, that you consider liking, subscribing, and commenting on the videos. These are the type of things that gets this video kind of pushed to broader audiences, and it can really help us.
It's interesting, yeah, because no one's taking an ultrasound to the brain to find to find signs there. Maybe one day we'll find something on fMRI or some of these other tools that they could look at, but it reminds me in many ways of the suicide issue with antidepressants, where after, and this is another David Healy thing, when he was talking about it in 1991, they were saying that the patients who were claiming that the drugs made them more suicidal were it was coming from their underlying depression and not from the drug, and it took about 15 years for people to finally realize that that was not the case. And all central nervous system drugs have paradoxical effects in some people, and if they happen in people who are depressed, it could make them suicidal. Just like if you were smoking weed with a bunch of your friends, 4 out of 5 might be pleasantly relaxed and laughing, and one person might be paranoid and not having a good time. Drugs do not have uniform effects in all people for reasons we don't understand. And ultimately, with the suicide question, it was all about teasing out the quality of the behavior compared to their baseline, right? Because if someone's had maybe 20 years of depression and this is what it looks like and this is how they feel, and then shortly after coming on the drug, all of a sudden they're pacing all over the place, they're highly agitated. Sure, some people who are depressed pace a lot and are highly agitated, but what are the chances of the whole nature of someone's depression changing? And when you look at enough of those cases and you see a similar pattern of changes, it starts to look like there really may be something to it. PSSD is going to be harder because the problem with the cognitive issues with PSSD is there's no you can't it's not like you can remove the drug and it goes away. With the suicide issue, you could just remove the antidepressant and then within a few weeks they get better. With this one, you can't do that. And so it really has to be teased out symptomatically, right, in a pattern. And one thing that you might be interested in, and maybe talk to Dr. Goldstein about, maybe he'll even start asking people about this, is to ask people how they respond to drugs after they develop cognitive problems with PSSD, because a lot of people that I've spoken to have said that they no longer feel any euphoria from things like alcohol. I've had some people take trips on ibogaine or hardcore psychedelics, and they just say that it's just not affecting them in normal ways. And so I always think, that's really unusual to me when people start saying that stuff, because I've never heard of depression making someone kind of impervious to the euphoric effects of the drug. And so there's a few things in there that stick out to me as being like, wow, that's really odd,
right.
And I've heard this too many times for me to think, it's probably nothing.
Yeah. And so, two major points from what you just said. One is being able to distinguish what a sort of depression would look like versus an iatrogenic cognitive dysfunction would look like. And any means to do that would be helpful. And I also think the first point you made is absolutely crucial, is the brain is complicated, the body is complicated, and drugs are very complicated. And their interaction is then multifold complicated. And, we need to have some humility as researchers and clinicians in academia that, it's complicated. And so there may be multiple subtypes. Maybe there are some people who have, say, the pure sexual version of PSSD, where they have sexual dysfunction, but they don't have the cognitive things. I've seen patients have that too. And maybe there's another cohort where, they have sexual dysfunction, but they also have cognitive effects from the drug itself. And it's not due to depression. It's not, depression. It's not their original depression. It's not their depression secondary to their, if they even have depression secondary to their sexual dysfunction. It's truly from the drug. And that's a cohort of people. And for them, they could be, there's no subtypes of PSSD yet. Right, but the reason why we have subtypes of diseases is because people develop and research more, and then they find there are different cohorts of people who react differently. And so there may be two different cohorts of PSSD, and we'll label them later. The point is what you said, is that with any drug, pharmacologic, anything can cause all sorts of effects. And we need to be humble in terms of labeling things and revise it as needed.
It's interesting, it was just dawning on me that there could be a cohort of people out there who don't have sexual dysfunction, but they just have blunting, because when we think about it, what are the most common effects of these drugs? They're emotionally constricting, 100%. They reduce anxiety, and for a lot of people that feels like blunting or dissociation, this kind of separateness. And just like the sexual dysfunction may endure afterwards, maybe these states of disassociation could endure by other means, by there just being some way that the brain is not able to essentially spring back after the drug has been removed, for reasons that we don't understand. And so they could occur together, they could occur separately, and yeah.
And to that point, just, so, if we think about, one of the problems with these PSSD folks is that they go to their doctor and they say they have this, and they say, oh, your erectile dysfunction is due to, psychogenic reasons. You have depression, that's why you got the drug, right? So it's your depression. So it's hard, and obviously I did that as a researcher, and I was able to try to, tease that out, and Dr. Goldstein did as a clinician. But I'm talking about your average person who goes to their internal medicine doctor, and they're like, well, we have you're psychogenic, it's performance anxiety, it's, whatever. Mm-hmm. So similarly, for those people who are arguing about their cognitive dysfunction, they'll get the same response from many clinicians, which if they say they're, they feel, they have brain fog, oh, it's just your depression, it's just your depression in a different form, and then they'll probably give them another psychotropic drug, maybe a different SSRI. So the point is that with all of this, it's trying to tease apart through history, through other things like what you were saying in terms of response to other drugs. That's another avenue. If possible, maybe certain specific symptoms may be different. And then again, what are the odds that someone's, say, manifestation would be different than their, depression or whatnot, or normal depression? And then the third thing is, if possible, objective things, which, as you said, we can do that for the penis, although, this hasn't been really done for the penis either. And this is pretty, this is relatively new even within urology. But then, as you said, fMRI or something, if there's some way to objectively tease these things apart and say, whether it's your sexual dysfunction or your brain fog or both or whatever, is this from a drug? Is this from a psychiatric disorder? Those are all different avenues to try to distinguish this. And until we do so, there will, again, as I said in the beginning, there are doctors who go with the old school thought and doctors who want to, be the revolutionaries. I think it's important to be in a happy medium. It's important to be, think of common things, but then think of possible exceptions. And ultimately, we need is data. And that's the great thing about our papers. We have data.
From being in close contact with Dr. Goldstein and looking at charts over time, what can you tell me about the prognosis of this condition?
Yeah, so, Dr. Goldstein, I would say that's pretty much another paper, because and that will we'll think about trying to do that too. The only thing is that that's what I actually started doing 4 years ago, and then I kind of switched more to the diagnostic side. I would say the prognosis is mixed. I would say many don't show improvement, but some do show improvement. But to tease apart why and how is an extraordinarily complicated question, in part because Dr. Goldstein uses a lot of different tools at his disposal in terms of attacking this. And then in terms of trying to tease apart, what treatment is working or not working, that would be a whole research project in of itself. I would say just generally though, yes, there are definitely patients of his who have improved, and there are a few patients who have recovered. But there are also a few patients who have not recovered. So I know that sounds very vague, but I would be lying if I tried to give you numbers. But I would say there are people in all those groups. I would say that at least Dr. Goldstein, he regularly he sees PSSD patients regularly in a clinical level, and he treats them, and he attempts treatment and various treatments. And he's one of the very few who do in the world. And so I think, I think that sitting at home and not doing anything, at least, there are obviously many PSSD forums out there, and you will see people who are, have had this for 10 years, 15 years, just years and years, and nothing's happening, and they try various things, horny goatweed and all these sorts of, herbs and whatnot, and maybe it'll have some positive effect that's partial and transient, and maybe there is even something to it. Again, I'm not dismissing horny goatweed. I'm not dismissing anything, because we don't even know what the pathophysiology of this is per se, let alone what would any positive iatrogenic effect would be. That we're not at that level yet. But I would say that many of the people on these forums don't recover, and the prognosis is because there's no set treatment for this. There's no consensus.
Well, I guess what I want, on the forums, the forums for a lot of these drug-induced injury places, they tend to accumulate over time the worst cases, because the people who recover tend to leave. But I was hoping, in a kind of a cohort that might naturally just present, we would see something different, because you go on the forums, it's all doom and gloom. But it sounds like, like you said, you didn't say it's mostly bad. You said it's mixed, which is, maybe some people recover. Yeah, I don't know if you could speak to that. I work a lot with people who have kind of neurological problems when they come off benzodiazepines, and for them, I would say about a third recover within 2 years. The rest of them about the next 60% by year 5, and then there's a small group where it goes on. I don't know if you're anywhere close to kind of taking a stab in the dark for what seems to be happening in in this sort of all-comers cohort of people just turning up saying they have it, as opposed to just this online forums where everyone's super sick?
Yeah, so I would say that so it's a great point about the PhD forum that people who recover often don't come back, for whatever reason, or maybe they did try something and it worked, but they don't necessarily explain what worked. So that is true. I would say that yes, but part of that may also be true for our folks. I mean, there were patients who would show up every year and then they disappeared, and they didn't show up again. So why aren't they showing up to our clinic anymore, right? I mean. So, and then it's sort of, the ethics of research in terms of, well, should I call them and be like, hey, why aren't you showing up to San Diego Sexual Medicine anymore, and say, oh, you recovered completely from sexually and you don't, see a doctor anymore? Congratulations. I mean, that would be something to do, but potentially, although there's, I would have to think of the ethical ramifications of that in terms of research. So there, in other words, people drop out. The people who stay, as I said, I would love to give you numbers, but I honestly don't know the numbers, and I don't want to make them up.
I'll look for the paper eagerly, because I'm hopefully it comes.
Well, I should just this paper that we're hopefully the end of this year, early next year, is going to be more focused on the ultrasound, the diagnostics. It's not going to be focused on treatment per se. That is a very good idea for a follow-up paper.
Yeah.
But what I would say is that there are groups of both. There are some people who have completely recovered. There are some people who have, tried all the things that Dr. Goldstein is trying, and they've maybe shown some improvement, but it's transient, or whatnot, or it's partial. And then some are happy with that, and they're like, well, I have partial improvement, and, I can have, it's a mixed bag. That's the best I can say.
I mean, partial improvement's always a good sign. It's showing that the body is pushing back against the changes and recovering, and trajectory is everything, I think, with recovery from these injuries. A few more things I wanted to ask. One is just a simple one. How long does someone have to have sexual dysfunction after being off one of these medications for it to start to be considered abnormal, like PSSD territory? Because I will say, just within 1 degree of separation from me, I've known people who have had sexual dysfunction for 6 months after coming off their antidepressants, and they didn't say anything, and they were just like, I just thought it was normal. And then, thankfully, it recovered for this person that I know. What's your take on that?
So I think the definition that we used is a minimum of 6 months. If you look at, there's a paper from Israel in 2015, and they argued for, I believe, 1 month, and their argument was even if you take the, Prozac, which is the longest half-life, after a month, you should have your sexual dysfunction should come back. And, just from, and just speaking to my psychiatry colleagues, many of them say, yeah, I should come back within a few days, maybe a few weeks or something,
Sure.
6 months in general, not just for PSSD, but for erectile dysfunction, period, from any cause, for ED, which has also been researched for decades. And Dr. Goldstein is literally one of the leading world's experts in ED, period. 6 months is sort of the minimum that you have to have. And I would say, frankly, in our cohort, I mean, maybe there's 1 or 2 people who were 6 months, but the vast majority are way more than that, much more than that. And even the 6-month people, I think that are pretty recent patients who, there's more awareness about PSSD, so they're catching it. Frankly, most of our patients are, they went to a number of doctors. They were told it's all in their head. It's all psychogenic. It's from their major depressive disorder, and this isn't a real thing. Or they just get told, okay, here's, maybe a few of them will be given Viagra or something, and be like, oh, well, which obviously won't work. They don't have libido, they don't have anything, and obviously, as we show, there's, lack of tissue and whatnot. So, and then they go around with all these doctors, and they're told that this is all in their head, and then somehow they found out about Dr. Goldstein, through a forum or through whatever, and then they land to Dr. Goldstein, 2, 3, 4 years, 5 years after this. And so even the ages, and we'll say this in the paper, the ages that I mentioned 70% less than 30, that age is the age when they first show up to the appointment, in-person patient appointment. That is not the age. That's not the age that was 6 months prior to, or 6 months after discontinuation of the drug. That would be even younger. The mean would be. So yeah, I would say 6 months minimum, but honestly, in the real world, it's usually more than that.
Another question, and I know we talked a lot about penile tissue. What do the ultrasounds show in women?
You're giving me all the good research ideas. um, so Dr. Goldstein, he's kind of the world guru on erectile dysfunction and male dysfunction, but he's also kind of the guru in women's dysfunction. He wrote the textbook literally. He wrote the book literally on women's sexual dysfunction. Um, so I would say it's interesting because women are prescribed more SSRIs than men are. I forgot the ratio. It's almost 2 to 1. I think they're prescribed more. So you would think. I would say I have data going back to when I don't know. I think we started in at least 12, 13 years ago. I would say the women patients for PSSD are relatively recent. He's seen PSSD for 12, 13 years now for men. For women are relatively more recent. And so when I started the project, we had way more men than women, and then we were thinking about including both, but then we decided just to focus on the men to keep it a pure. Again, it's about limiting scope of the paper. That's all. But that is one of the many research ideas for the next paper, is to focus, and one of them is women. And recently, in the past, I would say, 2, 3, 4 years, especially when I've been busy with, this cohort of men, Dr. Goldstein has seen more and more women patients who are coming in with PSSD. And so the question then is, how do you assess those women? And do we have an objective measurement? Can you ultrasound the clitoris? I'm not sure. And honestly, that's above my pay grade. That's not something that I've done research in. That's not something I'm really equipped to talk about. Dr. Goldstein, would be the perfect person to ask that question. I mean, I'm throwing that out there, but I don't think it's as easy or as straightforward in terms of just taking an erect penis and putting an ultrasound probe and seeing the muscle. I mean, it's a relatively straightforward concept if you think about it. With women, though, how can you really demonstrate in a radiologic or objective fashion? I'm not sure.
It's above my pay grade as well, I have to say. So, yeah. Okay, great. Those are about all the questions that I had. What else haven't we touched on? What do you think is interesting? Anything else interesting that you'd like to speak with the audience about?
I would say that it's all about data collection. It's all about analyzing people and their stories and trying to find more and more information. That's the way research is done. That's the way science works. That's how medicine works. And so the more data we have, the better, and the better we can refine these things. And as I said, our definitions now, our definition may be totally different in 5 years, in 10 years, in 15 years. And we may have subgroups of these things. And I would say to anybody listening, I would say consider PSSD as a serious possibility. Go to Dr. Olson, obviously a doctor, but he's trained multiple fellows, from Washington D.C. to the West Coast, or another sexual medicine expert. I would who knows what they're doing or can refer you to the appropriate person. Because if we don't have data, we can't analyze it further, and then we're kind of just in the dark. And I would say it's something that antidepressants, I think, are now like the leading drug class in the country. I think they've surpassed statins, even, if I'm not mistaken. I think they're second, now they're first. I mean, I think like 15% of American adults are on antidepressants, or 10%, or some insanely high number.
COVID really pushed it into the number one position.
Yeah, right. So I would say that, it's important to take seriously as a patient. If there's any providers or clinicians out there, I would say consider it. There's good research on it. There will be more research, as you will see in a few months, that shows that this is a real condition. It should be seriously thought of. It should be obviously, part of the informed consent process. And you can qualify it by saying this has to be researched more or whatever, of course. But it is what it is. And I would say that whether it's a researcher, a clinician, or a patient, or maybe a family member of a patient, take PSSD seriously and try to invest in it accordingly. And if you're a patient, go to the appropriate doctor so you can try to get better, and or just give us more data so we can learn about it further. And that may help you later on, even if it doesn't help you immediately. And so I would say there are very smart people working on this and thinking about it, but we need help, as much help as we can, to raise awareness about this. There's a paper just published, I think this year, the same Israeli group, and they were trying to calculate the incidence or prevalence of this. Even if it's a small percentage, 1% of 15% of American adults, or even 0.01% rather, that's still hundreds of people, thousands of people potentially.
It's like tens of thousands of people.
Yeah,
probably.
Yeah,
who have this. Yeah. It's millions. There's millions of people on these drugs. Well, great. I want to thank you so much again. It's been a pleasure talking to you, and really excited to read all the publications coming out soon.